Hi friends, I Dr. Pankaj Anand welcome you on behalf of the ACE Academy of Clinical Education to this live class today. Friends, just before we proceed with the class, let me just give you a brief background of the organization. It's last 15 years that the ACE Academy is operational. We have been training doctors for the last 15 years on various aspects of modern acute care. We've done more than 16 mechanical ventilation workshop, which is our flagship course. We've had some of the best teachers, not just from India, but outside as well. We've done around 12. We've done 12 workshops on hemodynamic monitoring, besides trauma workshops, besides BLS, ALS courses. Dr. Ashish?
Yeah.
Now, it is for the last 3 years that the ACE is organizing these online courses. At the moment, we have 3 important topics that are being covered in our fellowships. Of course, there is the Mechanical Ventilation Fellowship Program, which is pretty popular. We also have the Nephrology Critical Care Fellowship Program, and we have also introduced the ACE Emergency Medicine from this year. I'm very happy to share that we have an overwhelming registrations in our various programs with over 300 students registered all across, not just in India, in far off places, even in Saudi, Sri Lanka, Nepal, Bangladesh, etc. Now, coming to today's class, we are, of course, going to discuss one of the most important topics on modern acute care, which is how to interpret an arterial blood gas sample. And I'm personally indebted and also obliged, honored to have Dr. Ashish Jain with us, who is a very well-known teacher. He is head of the department critical care medicine and also a very senior pulmonologist at the Mahatma Gandhi Medical College and Research Center here in Jaipur. And over the next few minutes, Dr. Ashish is going to delve deeper into the various aspects of what that report, that ABG report that you see, what it tells us directly, indirectly, how to interpret it, and how to manage our acutely sick patients with the help of the report. Now, before I hand over the proceedings to him, just a request to all of you. Please ensure that your microphone is switched in a mute, is put on mute at this moment. Also, please put your video on the stop video mode so that there is no disturbance while he's teaching. Dr. Ashish, over to you,
yes, sir. Yes.
Please start proceedings from here. Thank you.
Thank you, Pankaj Anand boss, for giving me this opportunity to present here about ABG. And at the outset, I would like to thank Dr. Ram Rajgopalan also. I used few of his slides for making this presentation. So we will discuss today about ABG, and there is many ways to interpret the ABG report, but we will learn one basic and simplest methodology to identify the acid-base disorders. I hope I am audible to everyone, and I request everyone to please keep yourself mute so that the voice quality would be good. I'm now start my presentation. Okay, so let's move. So in the beginning, the goal of his talk is to provide one approach for the interpretation of blood gases analysis. We are not going in detail of the physiology of respiratory gas exchanges, as well as not going to discuss in detail about the acid-base regulation by the kidneys and lungs. And as I said, we will discuss about one approach for the interpretation. So there could be many other alternative approaches also, but we will restrict ourselves for one approach. So in the beginning, what is pH? pH basically is a negative logarithmic scale of H positive ion. That means it is indicative of H positive ion concentration in the solution. What does negative means? Negative means that the pH value get lower as the H positive ion concentration increases in the solution. And it is a log. Log means if there is change in 1 from say about 7 to 8 or 9 to 10 or 7 to 6, there is 10 times more change, 10 times more change in the concentration of H positive ion. The aim of this regulation between acid and bases in the body is to maintain the pH within a very narrow range. Our normal pH range from 7.35 to 7.45. This range we can tolerate from 6.5 or 6.7 to say about 8. The life we can sustain life with so many problems. So our whole body is trying to maintain this pH with the help of buffers or lung and kidneys to maintain the pH in this narrow range. The pH homeostasis is accomplished through the interaction of lung, kidney and the buffers, and this interaction is very well represented by an equation which we all know is known as Henderson-Hasselbalch equation. It is written below. So as we discussed that the life is compatible between 6.8 to 8 pH, and even if we go beyond the normal range from 7.35 to 7.45, it will cause a lot of problems. Few terminologies we should know. What is acidemia? Because whenever we see an ABG, we say it is acidosis, it is alkalosis. So actually, if the concentration of H positive ion increases in the blood, that is called acidemia. If the pH is below 7.5, it is acidemia. All right, like hypoxemia, okay, like hypokalemia. The similar word it is mia, like acidemia or alkalemia. It is the blood pH which goes beyond 7.35 or 7.45. But acidosis is any process which leads to decrease in the pH, and any process which leads to increase in the pH is known as alkalosis. What is acid? Acid are the substances which releases H positive ion in a solution when it is dissolved in it, such as citric acid or carbonic acid. When carbonic acid releases H positive ion, it decreases the pH. Similarly, substances that accepted the H positive ion when dissolved in the solution and reduce the concentration of H positive ions are called as base, such as bicarbonates, phosphates. They accept H positive ion and reduce its free concentration in the solution, so it improves the pH. Buffers. Buffers are the substances that can either accept or release H positive ion depending upon the surrounding H positive ion concentration. So buffers are basically substances that resist big changes or big movement in the H positive ion concentration, just like a sponge. For the maintenance of this acid-base balance in our human body, there are three systems. One is the buffering system, primarily managed by bicarbonates, lung and the kidneys. And we have few other buffers also that are called the phosphate buffer and protein buffers. Bicarbonate buffer is most importantly, and it is present in extracellular fluid as well as intracellular fluid. Phosphates are primarily present in the intracellular fluid, while proteins are the largest buffer store, and mainly it is a bit of albumin and globulins and hemoglobins in the intracellular as well as extracellular fluid. So carbonic acid and bicarbonates, these are always in a neutral condition, and whenever there is acidemia, the bicarbonate binds to H positive ion and it reduces the H positive ion concentration, and similarly with the bicarbonates, the carbonic acids. We know that carbon dioxide is produced by the aerobic metabolism in our body, and it is released in atmosphere through the help of our lung. And if there is any pathology, so the carbon dioxide excretion is decreased and it's causing the hypercarbia in the body, and then it will really reduce the pH. Similarly, kidneys, they excrete H positive ion in the urine in the form of ammonia, and they reabsorb H bicarbonate ions. And these bicarbonate ions bind to the H positive ion and they improvise or they improve the pH. So they reduce the H positive ion concentration. The maintenance of acid and base balance by these two systems is known as the compensation. So if kidney fails to excrete the metabolic acids, ventilation is increased, such as if there is lactic acidosis or if there is ketoacidosis, patient is having tachypnea and hyperventilation. And this hyperventilation is to excrete more amount of carbon dioxide from the body. Please mute yourself, everyone. And everything is, we can, this acid base equation is managed by this equation. When there is carbon dioxide production, it is bound with water to produce carbonic acid. This carbonic acid is then break into H positive ion and bicarbonate ion. So if there is increase in carbon dioxide, more amount of H positive ion will be produced and patient will have acidemia. pH will drop. And if there is more bicarbonates, then these bicarbonate will bind to the H positive ion present in the solution or in the blood, and they reduce the pH, and this H positive ion binding to bicarbonate will release carbon dioxide and H2O, or that means water, and this carbon dioxide is released in the atmosphere. Then there is PCO2 and bicarbonate ratio. This hydrogen ion concentration in the extracellular fluid is determined by the balance between CO2 and bicarbonates. And there is an equation that is called Henderson equation, which equates that H positive ion concentration equals to 24 into PCO2 upon bicarb. Remember everyone, this is the most important equation because it relates three important part of the acid base management. One is H positive ion concentration. It is depending upon the PCO2, that means lung, and bicarbonate, that means kidneys. Normally, the normal H positive ion concentration is 40 nano equivalent per liter. Whenever there is compensation happens, if it is a respiratory compensation, it can happen in minutes. But if it is a metabolic compensation, then it takes days to settle down the pH changes. And one more important thing, overcompensation never happen. It does not occur. If there is acidosis, that means if pH is less, suppose if pH is 7.20 and compensation starts, it cannot cross 7.40. It may reach up to 7.4, 7.39, 7.38 in the normal range, but never crosses until unless there is something else, some other pathology is present.
ঠিক আছে জি ওকে
Please mute yourself. So now comes the sampling. Sampling is also very important. First, we have to confirm whether there is need to take ABG or not, because many a time we have seen for suppose if you want to know creatinine concentration, so you order an ABG, or you want to know the sodium concentration, you order an ABG. And then we should always record the details of respiratory support. How much oxygen is going on, what is the ventilatory parameters which is there, how much FiO2 is patient on, because this, what is the temperature of the patient. So these are the important things which we need to fill whenever, or we need to see whenever we are evaluating or judging an ABG. Then before start sampling, we should take a consent from the patient and explain the procedure that it is going to give some pain to you. Preparation is also important, and I will discuss later. And then we have to identify which site, radial, brachial, or femoral artery you are going to prick. Preferably in an OPD situation, you should ideally prick a radial artery of a non-dominant hand. And we should be very careful that it should not be performed through a lesion or a surgical shunt if it is there, or inadequate collateral circulation, or if there is evidence of peripheral vascular disease distal to the puncture site, because it may cause problem to the patient. So how to identify the collateral is there or not? We should do a Allen's test. But remember one thing, that the value of routinely performing Allen's test prior to arterial puncture has been questioned, and the sensitivity and specificity of this test is very low. How we do it? Because we know that there are two circulation system in our hand, that is ulnar artery is there and radial artery is there, and they form a collateral. So we test both of these systems for the collaterals to have. Then we should position the patient head at 20 to 30 degrees extension, and we can achieve this by placing some cotton roll below the wrist. Then we should choose the site, we clean it with alcohol swab, and then we should use the alcohol or the ABG syringe, which is 1 to 2 ml of syringe with very small needle, and we should introduce this needle 45 degrees with bevel up. Now we should go very slowly, because if we do frequently, or if the number increases, then the artery may go into spasm. Then we should look for the flush of pulsatile blood. Syringe feels some under pressure, that means we have pricked the artery, and you can aspirate the blood inside the syringe. And then once you have withdrawn the needle, then you should compress the local site for at least 5 minutes. This is how you should do a Allen's test. Compress both radial and ulnar artery simultaneously, and then release the ulnar artery to see whether whole of the palm is supplied by it, or it has turned pink or not. There are some important factors we should know during the preparation of an ABG. One is the steady state. Blood sample must be done during the steady state of ventilation. That means if you have started oxygen to your patient, or if you have made some changes in the ventilatory parameter of the patient, then should wait for a few minutes before you withdraw a arterial sample. In a patient whose lungs are not compromised, wait for 3 to 10 minutes. Or if a patient who already have a chronic lung disease, then you should wait for 20 to 30 minutes to achieve the steady state. Anticoagulant, it is also very important, because many a times our nursing staff take 1 drop or 2 drop of heparin in the syringe. It is 0.05 ml of heparin is required to anticoagulate 1 ml of blood. So how to achieve it? You take the syringe, you take 1 or 2 ml of heparin in it, and you flush it out. Whatever heparin is there in the dead space of the syringe is adequate for anticoagulating the amount of 1 to 2 ml of blood which you are going to withdraw for the ABG analysis. Because it should be known that increase in the heparin can cause decrease in pH and decrease in carbon dioxide level due to the dilutional effect. Then if you are not able to process the sample immediately, then what to do? Because blood is a living tissue, oxygen will be consumed and carbon dioxide will be produced in the blood sample. So in case of delay, you should use ice box or place this syringe in between the ice packs, and we can wait up to 1 to 2 hours. And we should avoid taking venous samples if you want to know about the oxygenation status of the patient. How to test that this sample is venous sample or this sample is arterial sample? The best way is to see the PaO2 and PCO2 levels. The SpO2 level and the PaO2 levels are low, and the carbon dioxide level is generally high. As well as we are not going to feel the gush of blood inside the flash of blood inside the entry when you enter into the blood vessel. We should also ensure that there should not be air bubble in the syringe. Some few 3 or 4 very fine bubbles, it's okay, but not a big bubble, because it will increase the PaO2 and decrease the carbon dioxide level. Now coming to the anatomy of a blood gas report. So what are the things which are printed on the blood gas or ABG report? So there are measured value. These are 3 values, that is pH, PCO2 and PO2. These values measured by your machine. Then corrected values. It is a calculated value which machine did for the temperature corrections. Calculated value based on the Henderson-Hasselbalch equation. These are the values which is calculated by machine, primarily the bicarbonate levels. And enter data. Enter data means the things which we need to fill up when we are going to start the machine or put the sample in the machine. These are the temperatures, concentration of hemoglobin, and FiO2 or oxygen, how much oxygen is going to the patient. Now coming to the corrected pH, PCO2 and PO2 levels. There are many studies and many authors now say that there is no specific basis for applying the temperature corrections in the blood measurement. We should not see it. It is valuable when patient is having a severe hypothermia or hyperpyrexia, then the corrected values are of some use. And we know that uncorrected pH and PCO2 level to the temperature are very much reliable, and they are reflecting to the in vivo acid-base status of the patient. There are 3 electrodes when we see the machine which measure the pH, PCO2 and PO2 levels, and there are some additional options includes in the machine. There are the co-oximeters for the measurement of oxygen saturation, electrolyte measurement and hematocrit measurement. In some new machines, you can measure lactates, creatinines, bilirubins also. Coming to the bicarbonate, which is a calculated value, and it is calculated with the help of Henderson-Hasselbalch equation. Something about standard bicarbonate. Standard bicarbonate means it is the value of bicarbonate which is after equilibration of PCO2 of 40 mFHg. So suppose say in this ABG, if you see PCO2 is 44, then the bicarbonate actual are 31. If PCO2 would have been 40, then 30.5 is the standardized bicarbonate value, and it reflects non-respiratory acid-base changes. But it should not be considered actual buffering capacity of the blood, and we are not generally consider it as the actual value. Base excess or base deficit. Base excess or base deficit means how much bicarbonate or how much base you need to remove or add to the solution to make the pH 7.4 at the PCO2 of 40. It reflects the metabolic portion of the acid base, and many times it is misinterpreted in the chronic diseases or the mixed disorders. If it is not a mixed disorder, then you can say, oh, base excess is there, then that means carbonates are high, so it is alkalosis. So use these 2 terms in caution. Coming to the oxygenation part of the ABG. So we should see the PaO2 or the arterial oxygen level, partial pressure of oxygen level, and it is depending upon the age of the patient, how much oxygen we are giving to the patient, that means FiO2 and the atmospheric pressure. If age increases, the expected PaO2 is decreased by this formula, that is 109 minus 0.4 into age. And if we give more oxygen to the patient, naturally the PaO2 level will increase. We should be very well aware about the alveolar gas equation, where we would calculate the alveolar oxygen concentration, the partial pressure of oxygen in the alveolar gas. And this equation should be remembered very well. So if you see, there are two parts in this equation. This portion, Pb minus PH2, is called the into FiO2. This portion is called the partial pressure of oxygen in the inspiratory gases, or PiO2. And this is partial pressure of carbon dioxide, which we can get from the Abg, and R is the respiratory quotient, which is 0.8. So in a normal atmospheric pressure, when the 21% of oxygen is present in atmosphere, the PiO2, or oxygen partial pressure of oxygen in inspired gas, is 150. So 760 is the atmospheric pressure, and 45 is the water pressure, and it is multiplied by FiO2 0.21. So it is, the value comes here, it is 150 mm of Hg. And to get alveolar pressure, we deduct or subtract PCO2 upon R from PiO2. That means 150 minus 40, which is normal PCO2, upon R, that means 0.8. So normal alveolar oxygen pressure is 100 mm of Hg. So the gradient is 10. That's how we calculate our alveolar arterial oxygen gradient. The normal value ranges from 5 to 15. If it is an oxygen failure, if the concentration of oxygen is low, then PiO2 will remain same at atmospheric pressure and at 21% oxygen. PCO2 will be same because there is no hypoventilation, but alveolar pressure, if you calculate 150 minus 40 upon R, it is 100. PaO2 will be low because there is low FiO2, oxygen failure is going on. So the gradient is high. If there is ventilatory failure, can see the PA2 is normal, PCO2 is high, and PO2 is also normal, and the gradient is 10. So if the gradient is increased, then you should see whether low PO2 is correctable with oxygen. So now we are going towards the causes of high alveolar arterial oxygen gradient, or high gradient. Then we should supply or increase the oxygen supply to the patient. If PO2 improves, then it is due to the VQ mismatch, or if PO2 doesn't improve, then it is because of the shunt. Second, if there is no increase in gradient, then it is because of the low oxygen, low inspiratory oxygen, that means high altitude or decreased FiO2. On the other hand, if there is hypoventilation and gradient is increased, then it could be because of hypoventilation plus some other mechanism, could be shunt or VQ mismatch, or if there is no gradient and hypoventilation alone due to the decreased respiratory drive or neuromuscular diseases. There are certain more parameters are printed on the ABG machine related to oxygen, and there are some limitations are also there. Oxygen content, as we all know that the oxygen content can be calculated with a formula which is 1.34 multiplied by hemoglobin concentration multiplied by oxygen saturation plus 0.3 multiplied by PaO2 concentration. Here on the ABG also you can have this oxygen content. The normal value ranges from 15 to 20 milliliter per deciliter. Oxygen saturation, we know that it is calculated from oximetry, co-oximetry, which is ideal measurement. And third is the alveolar arterial oxygen gradient, which you can see here. Ideally, you should measure it or calculate it, but you can see here it is either normal or high or low. Then fourth is the ratio, arterial alveolar ratio. It is proposed to be less variable, but it has limitations as a gradient. So what are the things which we should see in ABG report? The essential ones are pH, PCO2, PO2, bicarbonate, oxygen saturation, and the difference and the gradient. So what are the 7 steps for the evaluation of an ABG report? First of all, step 0. We should check for the validity of ABG. We should know the report which we are going to interpret is valid or this report is wrong. For that, we need to do one thing. We need to calculate the H positive ion. And we know by the Hasselbalch-Henderson equation, we can calculate H positive ion by placing the values of carbon PCO2 and bicarbonate in this equation. And we can have the H positive ion in nanoequivalent per liter concentration. Similarly, we can have a reference table, or we can call it the rule of 80. Here, deduct last 2 digits from the 80 and you will get the approximate H positive ion concentration. See here, if we say about 7.30, so you should deduct 30 from 80, you will get 50. 7.35, deduct 35 from 80, 80 minus 35, 45. 7.40, 80 minus 40, 40. 7.45, 80 minus 45, 35. So this is the approximate H positive ion concentration. So if this concentration is almost approximating this measured or calculating concentration, then we can say this ABG is of validity. Then we should proceed further. Then step 1, look for the pH. If the pH is less than 7.35, then it is acidemic, or if it is more than 7.45, then it is alkaline. For all the calculations and practical problems, when you are analyzing an ABG machine or you are calculating ABG machine, 7.40 is your center point. Below this is acidemia and above this is alkalemia. Then coming to the second step, is it metabolic or respiratory? So know the primary disorder, whether this acidemia or alkalemia is because of metabolic problem or from respiratory problem. So if there is high carbon dioxide, it is respiratory acidosis. If there is low carbon dioxide, it is respiratory alkalosis. Similarly, if it is low bicarbonate, it is metabolic acidosis, and if it is high bicarbonate, it is metabolic alkalosis. And these are the primary changes, these are the primary disorder. And we know for any problem with the lung, there is compensation by the kidney. So if there is high PCO2, compensation by the bicarbonate will go high. Okay. If there is decrease in PCO2, respiratory alkalosis is there, then bicarbonate will go down to maintain the pH after compensation. In metabolic acidosis, when the bicarbonates are low, carbon dioxide will also go out. That means there is tachypnea and high minute ventilation will be there to reduce the carbon dioxide concentration to maintain the pH after compensation. Similarly, if there is high bicarbonate or metabolic alkalosis, it is compensated by hypoventilation or retaining of carbon dioxide. Then step 3, if there is a primary respiratory problem, then we should know whether it is acute or it is chronic. You know that respiratory compensation is very fast. It takes hardly a minute time or an hour time to compensate. So it is very important whether this patient is having a chronic respiratory problem or a acute respiratory problem, and for which we need to calculate the expected pH. You need to remember these two formulas. For expected pH in acute conditions, you multiply PCO delta PCO, that means change in PCO2 from 40 by 10 2.08, and you should, for chronic disorder, you should multiply it by 0.03. And if expected pH from 7.4 is nearer whatever we find it on the ABG is close, then it is acute or chronic. We will see one example for this also. In step 4, once we identify that this is respiratory problem and it is acute or chronic problem, then comes how much compensation is there for this respiratory problem. So if it is an acute compensation, then expected renal compensation for every 10 change in the PCO2 level from 40, there will be 1, 4 and 2, 5. You can remember this slide. So if in acute respiratory acidosis, if bicarbonate level, if PCO2 level rises 10 above 40, bicarbonate will rise 1. If it is chronic respiratory problem, there is 10 changes in the PCO2, say about PCO2 is now 50, 10 more than the 40, then the bicarbonate will be 28. So that's how you calculate. 2 and 5, that means, so if it is respiratory alkalosis, PCO2 will be low, bicarbonate also going to go low. So every 2, that means if PCO2 goes 30 from 40, so 10 this 10 number fall from the normal value, then the bicarbonate will be 22, 24 minus 2. And if there is chronic respiratory alkalosis, then bicarb level will change by 5 for every 10 in the PCO2 change in the PCO2 level. Then comes the step 5. We have done about the respiratory changes, and we have identified primary respiratory disorder, if it is acute or chronic, and what is the compensation for the respiratory problem. Now at step 5, we came to know about the metabolic problems. If we have identified that the disturbance is primarily metabolic, that means primarily bicarbonate are low for acidosis and high for alkalosis, then we should calculate the respiratory compensation, and we should see whether it is appropriate, that means fully compensated or partially compensated or no compensated. So how to calculate? So there are two formulas. Winter's formula for expected PCO2 in metabolic acidosis, 1.5 into bicarbonate plus 8 plus minus 2, and for metabolic alkalosis it is 0.7 bicarbonate plus 21 plus minus 2. If this expected PCO2, can you please mute yourself? So if this actual PCO2 is more than the expected PCO2, then there is hidden respiratory acidosis along with metabolic acidosis. And if there is actual PCO2 is low than the expected, then there is hidden respiratory alkalosis along with metabolic problem. Step 6. If it is metabolic acidosis, then we need to know about the anion gap. What is anion gap? We know that we should calculate it by subtracting chloride plus bicarbonate from sodium concentration. It is basically, we know that there is electron neutrality in the serum. Total serum cations should be equal to the total serum anions. And what are the cations and anions? There are major cations like sodium and unmeasured cations like potassium, calcium, magnesium. Similarly, major anions are the bicarbonate and chloride, while some not major ones are the phosphates, sulfates, proteins, and organic acid. So there will be relative evidence of the anions. So anion gap is calculated by subtracting bicarbonate plus chloride from the sodium. We sometimes some of the persons add potassium also to the sodium, but potassium concentration in extracellular fluid is quite low. So the anion gap is calculated using this formula, sodium minus chloride plus bicarbonate, and generally this value is less than 12. Dr. Prabhat, can you mute yourself? So if the value is more than 12, then it is called high anion gap metabolic acidosis, and there are few reasons for this which we need to learn. Simple mnemonic is mud piles, that is methanol poisoning, uremia, diabetic ketoacidosis, lactic acidosis, infections, salicylate poisoning. You do see a lot of patients. Glycol poisoning, we have seen some patients of this poisoning problem also. And uh, if there is hypoalbuminemia, then we should correct the anion gap also. So it is called corrected anion gap for the albumin, and the formula is anion gap plus 0.25 multiplied by 4 into measured albumin. In some patient, you are going to see low anion gap metabolic acidosis also, and in those patients could be lithium toxicity or bromide toxicity. Some patients are having psychiatric illness, taking lithium in their drugs or bromide preparations. So those patients might land up with some low anion gap metabolic acidosis. Uh, then there is normal anion gap metabolic acidosis. So the anion gap is 10 to 12, and these patients are, if you give a lot of normal saline to a patient, hyperchloremic metabolic acidosis is a part of kind of this normal anion gap metabolic acidosis. Then comes the step 7. Then we need to check the delta gap. Delta anion gap, we should calculate anion gap minus 12, and delta bicarb, which is calculated 24 minus bicarb. So if this method we are putting here to identify whether it is pure high anion gap metabolic acidosis going on, or some other disorder is also associated with high anion gap metabolic acidosis. Say suppose a patient of diabetes insipid, diabetes mellitus, type 1 diabetes, diabetic ketoacidosis came to you with pneumonia. So in those patients, you may have pure high anion gap metabolic acidosis with respiratory acidosis, or along if is resuscitated with lot of normal saline, then you have associated normal gap metabolic acidosis also. So how to identify these things? You should calculate the gap. So bicarb gap is calculated by subtracting measured bicarbonate from 24, and anion gap, delta anion gap is from measured anion gap minus 12. If these values are equal to each other, then it is pure high anion gap metabolic acidosis. If anion gap, delta anion gap is higher than delta bicarb, then it is associated with metabolic alkalosis. And if delta anion gap is lower than the delta bicarb, it is associated with normal anion gap metabolic acidosis. So these three things we should also remember. Now we coming to some cases we are going to solve. So this is a 30-year-old female with sudden onset of dyspnea, no cough or chest pain, vitals are normal but respiratory is 26, and patient is anxious. This is the ABG report. So if you see, we need to calculate whether this ABG report is validated or not. So if you see here, the pH is 7.52. So with this, if you calculate with the rule of 80, the expected H positive ion is coming around 28. And if we measure it with the Henderson-Selbeck equation, it is 24 multiplied by PCO2, that is 30.1, and bicarb 23.9. It is, the value is reaching about 30. So these two are approximating each other, very similar to each other. That means it is a valid ABG to be interpreted. Case 2. A 60-year-old male smoker with progressive respiratory distress and hypersomnolence. Probably this patient is having COPD with type 2 respiratory failure. So now we need to calculate the ABG. So it is it acidosis, or is it acidemia or alkalemia? So it is acidemia because pH is less than 7.35. PCO2 is 76.2. So it is a primarily respiratory acidemia. Now, is it acute or chronic? That also is very important. So if you see, what is the change in carbon dioxide concentration? 76 minus 40, that means 36 m of Hg is higher than the normal. So if it is acute, then pH would be, if you remember the equation there, 0.08 multiplied by change in PCO2 divided by 10. So it is coming 0.29. So expected pH would be 7.40 minus 0.29, 7.11. If it is chronic, then 0.03 multiplied by 36, that is delta PCO2 divided by 10, and the value is coming 0.10, and expected chronic pH is 7.40 minus 7.10, so 7.30. By calculating this, we came to know that this patient is having chronic respiratory acidosis, because by calculation we came to know that pH is more nearer by the chronic one. Okay, now coming to the compensation. So how much compensation should be there? If it is, we know that it is chronic. So every 10, if you remember the formula 1425, so 4 bicarbonate level should raise by 4 for every 10 changes in the PCO2. Here how much changes? 36. So 4 by 10 into 36, 14 value should change in the bicarbonate. So what should be the expected bicarbonate? 24 plus 14, 38. Here it is coming 36. So it is fully compensated. So it is primarily a pure respiratory acidosis. No other disorder is hidden. Now coming to PO2. PO2 is low, that is 45. Normal PO2 value is 90 to 100 or 80 to 100. Patient is having hypoxemia. What about gradient? Gradient is normal. The normal gradient is 5 to 15. Here the alveolar arterial gradient is 9.5. So you can see it is normal arterial alveolar arterial gradient, and everything is happening because of the hypoventilation. So this patient is having COPD with primarily hypoventilation, chronic respiratory type 2 acidosis, type 2 failure. Coming to a new case, a 18-year-old male asthmatic, 3 days of cough, dyspnea and orthopnea, not responding to usual bronchodilators. On examination, patient is having respiratory distress, suprasternal and intercostal retractions, and tired looking because of the exhaustion, and patient is on 4 liter of oxygen with nasal cannula. This is the ABG. The pH is 7.23, that means it is acidemia. PCO2 is high, so it is going in favor of acidemia, so primarily respiratory acidemia. Then coming to the compensation for it, before that we need to identify it is acute or chronic, so calculate. So for acute pH changes, it is coming 0.6, and if we subtract 0.16 from 7.40, the pH is coming nearby 7.2. So this patient is having acute respiratory acidosis. For compensation for acute respiratory acidosis, we know there is 1 rise in bicarbonate level for every 10 changes in the PCO2, 1425. So there will be how much change in the PCO2 level? 20. So there will be 2. So expected bicarbonate level will be 26. Here it is coming 24.5. So is there any metabolic acidosis along with this respiratory acidosis? We should see. Then coming to the anion gap. Anion gap, if you calculate, sodium is 40, chloride is 100, and it is 24, then it is coming 16. So it is high anion gap. Patient is having hypoxemia. PiO2, if you calculate, PiO2, just a moment, let me finish it first. So if you calculate, because we know that there are 4 liters of oxygen going on, that means 30% of FiO2 is going on. So if PiO2 is calculating 715, that is 760 minus 45, multiply by 0.3, it is coming 214, and we calculate alveolar oxygen 214 minus PCO2 upon 0.8, 60 upon 0.8, so value is coming 129. Now this is the alveolar oxygen, and if you want to calculate the gradient, then the gradient is 129 minus 66, so it is quite high. Coming to case 5, a 28-year-old diabetic patient with respiratory distress, fatigue and loss of appetite. Again, patient is having low pH, that means acidemia. But why there is low pH? Is carbon dioxide level high? No. Is bicarbonate is low? Yes. So it is primarily metabolic acidemia. For metabolic acidemia, we need to see the compensation. So expected carbon dioxide level in metabolic acidemia is with the formula 1.5 into bicarbonate plus 8 plus minus 2. So if you put values, the expected bicarbonate, expected carbon dioxide will come 27 to 31, which is here 34. So what do you think? Some sort of respiratory pathology is also adding it? Let's see. Calculating the anion gap also. So values, if you put whatever is giving, anion gap is again 16. And this is normal gap is 12, 16 is, so delta gap is 4, delta bicarb is 24 minus bicarb, it is 10. So indicate additional non-gap acidosis. And why non-gap acidosis? Because patient is being treated with normal saline. So that's how you calculate by putting these following these 7 steps of ABG. And I'm again thanking Dr. Ram Rajgopalan because I have used few of his slides for the preparation of this presentation. And thank you very much for not becoming comatose. Any questions?
Excuse me. Hello.
Hello.
Myself, Dr. Mane from Shirdi. Sir, my one question is there. Compensatory phenomena and secondary changes, one and same?
Secondary changes.
Secondary changes and compensatory changes for the primary. They both are one and same?
Same.
Either we say it is a compensatory changes for the primary or secondary changes for the primary.
Yes, sir, we should use the word compensatory changes. Secondary could be some other pathology if it is associated with the primary one. Then it could be the secondary disorder associated with it. Say about respiratory acidosis along with metabolic acidosis in some situations you can have, or high non-gap metabolic acidosis with non-gap metabolic acidosis you can have. So it is not compensatory. It is some additional problem which is associated. So compensatory, we should say compensatory. Secondary, we should say additional. We say additional.
Sir, can you explain it again once, please? Some disturbance is coming in between, sir.
Yeah, some person is not muted.
Yeah. It's difficult to listen. Sir.
Ma'am,
If
please.
you have the rights, can you make them muted? Because I've been trying to do that.
Sir, I also trying to mute everyone, but it is loud. I couldn't see.
Dr. Mane, please
Yeah.
go ahead with the question.
Yeah. Sorry. Thank you, sir. Sir, my question is when to say changes are secondary changes and when to say changes are compensatory changes.
So compensatory changes are going with the disease itself. So, say with an example, if patient is having respiratory acidosis, type 2 respiratory failure is there, patient is having respiratory acidosis, and for the compensation, bicarbonates are high. You can add that this is compensated or not compensated. Secondary changes, if additionally some problem is also there, suppose you have given some bicarbonate to the patient or some Dimox to the patient or some steroid or some fluid, some diuretic, some additional thing you have done to the patient, and that is also being reflected, then it is additional changes. Generally, compensatory changes, you cannot cross beyond the pH of 7.40. You cannot cross beyond this. So compensatory changes, एडिशनल जो आप देख रहे हैं, जितने भी जो चेंजेस आप देख रहे हैं, इट इज एडिशनल वन. Like if you remember the case 2, it is pure respiratory acidosis case. We haven't said it is compensated by metabolic acidosis. We haven't said that. It is primarily respiratory acidosis, we said, and it has already been compensated. That's okay. We say some additional thing when it is there because of some additional pathology. Am I right, boss? Anand?
Yeah,
Dr.
yes,
Anand?
sir. Yeah.
Fully agree with you. Fully agree. Dr. Ashish, we also have question in our message box. It is Dr. Ashok Kumar Mishra, and he wants to know the difference between an arterial blood gas and a VBG. Can you just elaborate?
Yeah, though I have
Elaborate.
seen, I have shown that picture also. So in ABG, what you are going to see, number one, the pH. pH would be little bit less in the venous blood. PaO2 will be very, very low. PCO2 would be little bit higher, and SO2, saturation of oxygen, is lower than your whatever you are seeing on the monitor.
Okay. And he wants to actually know that if the patient is not hypoxic, then is it not a good idea that we don't go for an ABG, we just do a VBG?
Yes, definitely. But ABG is always not being done to see the oxygen content in the blood or oxygen calculation. It is many a times we did ABG for knowing the pH and the PCO2 and the bicarbonate levels.
Exactly. Exactly. There is one question by Dr. Venkata who wants to know that how can we detect methemoglobinemia in an arterial blood gas sample?
Difficult, because at our center it is, this value is coming printed on the ABG report by that machine already that calculate the methemoglobin levels, and I don't know how to calculate them if it is not being done by the machine.
Yeah, I would also say it is usually a part of the report if the machine at your center allows that.
Yeah.
Now another question by the same Dr. Venkata is that can we rely on the electrolytes that we see on the ABG machine? Do you do that in your daily practice?
Yes, for the acute situations, we have to rely on this, because if you send a sample for the laboratory, it takes minimum 2 hours to get the report. But we always confirm that report from the laboratory, our laboratory, by sending the sample. So as soon as the patient arrives to us, we do the ABG, we get the sodium potassium report, we start the treatment, but simultaneously send a sample to the lab and get the report to recheck it.
Exactly. I would add that we should correlate that clinically. If you are expecting a patient comes to you with an altered sensorium and you are expecting low sodium and your ABG shows the low sodium, go ahead and start treating till your lab reports come in. Same is with the potassium. Now, Ashok Kumar Mishra is asking, sir, if clinically you think metabolic cause, then why to do ABG?
So a lot of things you should you should learn. Like if I give you an example, if a patient is having diabetic ketoacidosis, a patient reaches to you with pH of 7.10 with high lactates, or a patient of acute liver failure with high lactate and low pH. Now you need to monitor these lactate levels as well as the pH level also. So for that you need to do an ABG. You know that it is metabolic component, but you need to do a regular EBG after an interval of say about 6 hours or 8 hours or 10 hours for for the identification whether your treatment is going in right direction or not.
Exactly. And Dr. Ashok, since you're asking again and again, why not VBG, as Dr. Ashish pointed out, and ABG just doesn't tell you only about the oxygen. It gives you a lot of other parameters, and that is where it becomes more important to go for an arterial sample rather than a venous one. Dr. Deepesh Mansingh wants to know that, can you please redefine about an acute versus a chronic?
Okay, let me start with an example. A patient coming to you in acute respiratory distress, and you identify that patient is having bilateral viral pneumonitis, and in ABG you have got with the history of only 2 or 3 days, with the pH is respiratory as say about 7.20. Similarly, you receive another patient who is non-smoker and who is experiencing respiratory distress for say about 15 days or 20 days, and that patient also have a pH of 7.20. Both are having high carbon dioxide level. Do you think these two patients are behaving same? One is patient is having underlying carbon COPD with which is coming after 20 days of its exacerbation, and another one is coming in 2 or 3 days with acute pneumonia. So primarily it is pathology which is giving us the problem. So in acute there is very fast deterioration happens to the patient, so pH will go down very quickly. That's why if you calculate, there is calculation of 0.008 with difference in the carbon dioxide level. While chronic respiratory pathology, if it is chronic, metabolic compensation has already started in the kidney. Kidney has already started its work. Kidney has already started compensating for the lowering pH. That's why change in pH is lower than the acute one. So the formula here is 0.003 multiplied by change in carbon dioxide level. That is the difference.
Yeah. Any other question? Anyone has another question? Please feel free to ask.
There is one question, some is asking that we should go for Abg co-oximetry. Yes, Abg co-oximetry is the ideal way to just for the oxygen level, as well as carboxyhemoglobin, methemoglobin, and so many other abnormal hemoglobins you can see in the co-oximetry and their levels.
Another question is there, I think. For ABG electrolytes, reliability or comparison with main lab reports, our ABG machine should be calibrated time to time. Yeah, of course. That is
Yes.
assumed that this is done. You told normal PO2 is 150, but very rarely we find it.
Normal PO2 is from 60 to 100 you can calculate. Yeah, it is there.
So, Smita, what he's saying is it's not normal PO2 is not 150, but it is from 60 to.
It is inspirated PiO2. I said it is 150.
Okay. Any other questions? I think we can go on. Right. So I think we've had an excellent presentation, Dr. Ashish. Personally, me and the entire student faculty and entire students and everyone is really thankful to you from the bottom of our heart for sparing not just one complete hour. I know you prepared for this. It's your Sunday afternoon. Your kids were after you for your time. And personally, we are indebted to you and your family and everyone. Thank you very much. One small announcement, the complete recording would be available and should be uploaded on the website in the next 24 to 48 hours. Some of you have commented that probably we should have gone slower, but 1 hour already with this speed. Otherwise, you would have ended for 3 hours. You can take the recording. You can play it at whatever speed you want. And thank you, Ashish. Once again, thank you very much.
Thank you, boss.
Bye.
Thank you, everyone. Thank you, everyone.